Okay, come on in and get settled. I know we've got people still milling around in the coffee area, and we've had all kinds of flight challenges. Apparently, there's a lot of activity going on. Weather-wise, that's caused a lot of delays, so I know people are coming in at different points in the day. But I do want to try and keep us on schedule so that we can at least make sure we have ample time for breaks and lunch and our demos and posters that are coming up. I am not Nancy Lorenzi, but if I were to have the honor of impersonating anyone, she is one of the top people that I would choose. Nancy also fell victim to flight cancellations and all kinds of issues with her travel that made it impossible for her to be here. But she really was instrumental in putting this panel together and had prepared some slides to introduce this panel and agreed to act as moderator. So I'm stepping in for her. I wanted to keep her name on slides and give her credit for this. I do want to just highlight what you're going to see in this panel, and our intent with this panel is to really paint the MCBK movement as a very broad movement, that there are many, many possible applications to this, and a lot of the clinical applications are obviously important and at the forefront of many of our minds, but there are really so many possible implications for this. And as we move this afternoon into the different work groups to start to tackle some of the problems with the standards, infrastructure, policy, and sustainability and inclusion, we thought it would be helpful to have some pictures of stories and scenarios in our mind of people that would be using this, using computable biomedical knowledge and benefiting from it, and some of the tasks and activities and actions that are happening. And so with that, we identified some broad areas, and these are just exemplars. These are not meant to be defining use cases for the MCBK, but just starting points as examples that people can have in their minds as we're trying to tackle through this problem that really crosses and cuts across so many different domains. So with that, I want to go ahead and move into introducing our great panelists. And a little more background, just foundations. Computable biomedical knowledge exists. And the purpose today is to provide some examples of this in multiple areas, to clarify opportunities and to understand how CBK can help change or improve that. So we've got four presenters, each describing a different use case. We're going to roughly give people, it's about 15 minutes per presenter, but we want to have an opportunity to have questions between the different presenters, because these are such different domains. We want people to ask questions when they're fresh in their mind after the speaker. So keep that in mind. You will have the opportunity to ask each panelist some probing questions about their use case and their perspective and context for use. And then we'll have some time for the panel as a whole to address some questions. So we're really hoping this will be very interactive. And my role is going to be what Nancy's role was, which was apparently to be the watchdog here. So I'll try not to be cruel or inflict any damage, but I'm going to try and keep us moving along so we can address each of these use cases in time. So first, let me introduce our speakers. First, we'll have Mark Overidge, who's the Chief Informatics Officer at Cerner. And he will be talking about clinical use case. Sean Granis, Director of Biomedical Informatics at Regan Strafe Institute, will talk about a public health use case for MCBK. And Anderson Spickert is Associate Professor of Medicine and Biomedical Informatics at Vanderbilt University, and he's going to talk about use cases in education and medical and health professional education. And Jenny Larkin is the Director of Research Evaluation and Operations at the National Institute of Diabetes, Digestive, and Kidney Diseases here at NIH, and she will talk about a research use case. So with that, we'll move on to Mark, who will be first. Okay. Let's see. I thought these were rolling. Oh, someone's doing this for me. Okay. I'm not doing that. Okay.
Awesome. Good morning, everybody. So first I want to acknowledge, there's been a lot of work going on use cases within the community, and these were created just to stimulate thinking and the breadth of the application of knowledge. And so we picked out, just for illustration, one clinical use case example of pediatric asthma, just to talk through, and not all of pediatric asthma, but a little snippet of pediatric asthma. And I want to start out by acknowledging, let's see, does our clicker work here? Or do we? Okay. I want to start out by acknowledging this scenario was really created by one of my colleagues who's here in the audience somewhere, Cole Erdman, working with the folks at Children's Hospital of Orange County when several years ago we started down this journey of creating interoperable approaches to representing the knowledge for these clinical use cases. And the example I was going to use here is Maria, who's a 9-year-old who lives with asthma in Orange County. What a shock. And as all of you know, in particular, I think interoperable knowledge becomes really, really important when you try to scale things. We think about population health, and the first thing that a lot of people jump to is, well, care managers. Well, and that's great for those few percent of the population that you can afford to invest human brain power in. The other 99% of the population, or 92% or whatever it is, you need automation to drive that, or you're never going to be able to scale to make sure that I follow up and get my colonoscopy or whatever it is. It's just too expensive to do with people. But the team's still very important for a lot of these purposes, and so Maria's team's very broad. Obviously, her parents, the school nurse, who on a day-to-day basis may help facilitate her care, her pediatrician down here in the bottom right, maybe a care coordinator, and perhaps that person who's looking at a little more of a population level, but that population's made up of thousands of Marias that are trying to get care. So the scenario that we thought through here, wanted to share with you, was just a simple one, and that is Maria is going to school. And it happens that, obviously with her asthma, she's taking her controller medications and so on, but people have exacerbations, and those may be triggered by environmental factors, for example. Maria happens to be very pollen sensitive. There are data that can be brought in through remote device monitoring, such as Maria's remote peak flow meter. And that data can be brought together and used in one form of computable knowledge, predictive models that we talked about a little bit earlier this morning. And there are a whole variety of those out there in the market, but as we talked about through the presentations in the morning, they're often not deployed and used for a whole variety of reasons. But once you have them in an interoperable format, the potential to move them from provider to provider and be able to really deliver at scale. And so the predictive model running in the cloud population health application is monitoring Maria's data and National Weather Service data. And tomorrow's going to be a bad pollen day, right? It's going to be a high pollen count, and the model says that Maria's risk of an exacerbation is increased tomorrow. And so the logic here, if you will, second bit of computable knowledge, the workflow that says, golly, when your risk of an exacerbation is high, do something about it. In this case, notifying Maria's mom and dad and the school nurse to let everybody know that tomorrow's a bad day and she's at high risk. Whoops, did I miss I missed an animation in here, which is delivering that message, but that's okay. And Maria is monitoring her asthma as she goes through her day, including at school through remote monitoring devices. And in this case, she happens to land, based on her peak flow at the moment, in her yellow zone of her asthma care plan. And obviously that needs to be a computable care plan, not a document, a piece of paper that Maria looks at and says what to do, or the school nurse looks at and says what to do, but rather that the algorithm, again, another bit of computable knowledge, is examining that peak flow and saying, golly, yellow zone, what do we do? Well, one of the things that we do is we notify the care manager that Maria is at increased risk today, and stimulate other actions. She might drill down and look at Maria's action plan, and based on that, follow up with various folks, including letting Maria's parents, in this case, know that she should make sure to have her rescue inhaler with her, and that she should wear or take a mask with her tomorrow if she's going to be outside, or maybe she should be excused from recess. Let the school nurse know that. so that she doesn't have to be exposed to unnecessary risk. So another bit of algorithmic computable knowledge, if you will, that drives that home. And then once Maria is through that day, and maybe she had a modest exacerbation and was in her yellow zone here, to follow up with Maria. So a third or fourth bit of computable knowledge, if you will, a computed questionnaire based on Maria's particular characteristics. In this case, well, the preventive measure that was intended was to wear a mask. Did she? Did she have to use her rescue inhaler today? And that kind of feedback loop driven by the, again, computable knowledge that says, what is the appropriate follow-up for this individual patient at this individual time is yet another bit of knowledge. And then, of course, providers who might be, in the case of Chalk, they have a breath mobile clinic, and they actually will schedule and coordinate those appointments, and the same algorithmic support for the scheduling and management to the providers who are delivering care in those settings. So this is a little tiny, and the point here I want to make is that's a little tiny vignette, but when you look at an overall program, as we call them, for managing pediatric asthma, there are literally hundreds of knowledge artifacts that are needed to enable that. And I think that's the real underpinning for why we need this portable knowledge approach, is that there are hundreds and thousands and tens of thousands of artifacts that are needed to improve the care delivery. And you simply, no organization, no commercial entity, no National Library of Medicine, is going to create them all. And so I just identified 4 out of 100 or so here that it takes for an overall just pediatric asthma plan or program. And so that's the one motivating use case, and we're going to move on in a minute after some questions to others. But I think the takeaway here is a lot of us, me anyway, often think about the clinical use cases. It's very easy to think of hundreds and hundreds of clinical use cases for portable knowledge. These same artifacts, and we didn't do this well with the panel, but if you think about many of these things, these same artifacts, predictive models for who's going to have an exacerbation, might be applied in research, might be applied in education, certainly relevant in public health. And it's just examples of how these same artifacts cross the different domains and the different use cases. So I'm going to stop there, and we've got a few minutes for questions. Dr. Greenis.
Bob Greenis. So a very nice model, Mark, because I think it touches on a lot of the things that we've also been addressing in the standards work group, and there's some other model use cases that also expand on this. One of the things that might be kind of the argument for why MCBK, rather than, or in addition to the perpetrators of the knowledge artifacts that you've mentioned, is how do you knit them all together? What is there like an overall, there's a care plan, a workflow, and it's going to need to be able to kind of oversee the process and pull in the various knowledge artifacts when needed. So I'm just mentioning that. I don't know if you have any comment on it, but I think that's an important aspect as well.
Yeah, I think that's a really important point, and it's always hard to know, where to stop in these things. But I think that notion of a interoperable care plan, if you will, that captures all of the things for an individual patient, and there may be dozens, right, or there may be 2, who knows? But all of those activities and processes that need to happen for the patient, generated by lots of pieces of knowledge. So that's one potential answer, I think, is thinking about a shared care plan as the pivot for all those pieces of knowledge feed into, and all of the relevant workflows. And that's a little bit what we're trying to illustrate here on this slide with the right-hand side, is whether it's the care manager or the patient or the physician drawing in their native workflows in the EMR or in the patient portal or in their asthma app, drawing from that shared plan. And so it's another set of standards and so on that I think are critical. So I'm with you completely. Why don't we go to this, the other side of the room, and then we'll come back.
I think this is great. It's getting my mind moving on, so what is a model? What's a clinical model? And I want to ask as sort of a devil's advocate, like, you know, if you just tell the people who are involved in Maria's care, it's going to be a bad asthma day tomorrow, there's going to be pollen, they all know what to do. They may need a reminder, but where, I mean, having the app would be great, but in terms of models that people are creating in the literature, I don't see this instance being sensitive enough that it would need to know more than was known 30 years ago. So when we're thinking about a model and interoperable models and stuff, I don't know, I'm just putting out some cynicism about, like, what do we really need?
Yeah, and that's why I think it's a great question. I think I get kind of the unease there. So a couple of things, one, or thoughts in response, not answers really. But one is that, at least when we think about things, you know, there's certainly things like model, really what I would think of as a model, a predictive model, it gives a risk or something like that. And that's one thing. And those are often not deployed for a whole variety of reasons. They're not generalizable, the data is not available, they're not sensitive or specific enough in this population, all those barriers. The second are workflows or process models where you need to make sure, you know, somebody gets told or some action gets taken. And then the third are sort of, if you will, quality measures, if you want to think about them that way, or at least those are three useful buckets we find to put things into. And you're right, you know, obviously we don't magically with interoperable knowledge fix any of the fundamental problems. You know, predictive model still needs to perform well. It still needs to be validated in external populations. It still needs to be rebuilt every couple of years, et cetera. And none of those things change. What I do think interoperable knowledge begins to change, and I think the little circle with the knowledge keystone at the top was a good representation of that, and we certainly think about it that way. Is it makes it easier to do that translation from now I've rebuilt the model and I can deploy it into use if, to your point, it's really good and useful. So like I said, not really answers, but a few thoughts. Whoops, the side of the room.
Hi, Brendan Delaney from Imperial College London, as you can probably tell by the accent. I think this is really fascinating because it's an archetypal chronic health problem that really unpicks this complexity of what's about workflow, clinical pathway, what's about predictive algorithms, and how do these fit together, and how do we move that ecosystem forward, where actually there may be a changing division between what's set in stone and something you should do and what's predicted from a model. And I can see that changing with time. And the problem is, at the moment, the workflow is embedded in proprietary tools within electronic health record systems, and it's not going to be tractable to create an ecosystem. Now, our group have been playing around, and we've got a post around with an approach to this developed by Frank van Harmenen's group in Amsterdam, the TMR model, the transition-based medical recommendations, which is a semantic web-based approach to expressing guideline statements. So I wondered if you'd looked into this area of how do we make semantically interoperable statements about things that can create recommendations for patients.
Yeah, no, I think it's a really important question. I think relates a little bit to the earlier question about how do you sort of integrate these things and so on. And at least in our day-to-day work, I'm not saying that's the answer, you know, we've been really looking at FHIR activities as the foundation for that kind of pivot point that says, the logic says, here's what's supposed to happen. The workflow now knows how to interpret that, what's supposed to happen. And whether that's delivered through a CDS hook or it's delivered through some other form, you still need, as you point out, the workflow applications to be smart enough to know there's an activity, to know there's a plan out there and go ask for it. But I do think that whether you do that using a Smart on FHIR app embedded in the application that knows that, or the application natively, and we've certainly seen willingness among, for example, EHR vendors to incorporate, local APIs to do that, or if the applications natively evolve to do that. It's a critical need, for sure.
Hi, I just wanted to maybe think through and point out how the use case for pediatric asthma might actually be like maybe one of the least interesting applications of this. And you might have an easier time thinking through how the kinds of patients who are working through multiple systems of care might really make something like this shine. I think about Maria Raven's project she did with Palantir, where she was working with street-involved alcoholics in San Francisco who are either in the emergency room, they're admitted, they're working with substance use counselors, they're interfacing with social workers, they're interfacing with folks trying to get them housed, they might be in jail. And if you're trying to provide those patients with regular care, you end up with a problem where you physically don't know where they are. They're involved at one point of a system on a given day, or they might be in an emergency room across town. So if you're trying to track hard to track patients, if you're trying to work with patients who are social work facing, if you're trying to work with patients who are at the intersection of clinical and non-clinical systems, I mean, I really think pediatric asthma is, I mean, if you want to do this with HIV positive patients, there are other folks that would see a lot of real world benefit from this. And they might not be the cutest patients. They might not be adorable little kids who can't breathe. They might be homeless folks. So maybe a different patient population would really help this stand out a bit stronger. Yeah, but other than that, I think it's good, yeah.
Well, and I think there's some, but again, you know, our goal here was just to get people thinking about the kinds of things. And I do think, as you described, I think these same issues of predictive models, workflows, so on, are the same things you need in these more complex scenarios. They're just more complex workflows and so on. You know, and I'll blame it on the committee. They said I only had a few minutes, so I had to have a very simple use case. Rachel, it's your fault.
Well, actually, in contrast to the previous comment, I actually think pediatric asthma is a great example of many of the complexities. I'm not known for being too controversial, but at least in public. But so the question, though, is that we've been trying. This is one of those areas that we know we need to be able to do better clinically, and yet we aren't. And so with pediatric patient-centered medical homes and the like, we've been putting so much energy, CMS has been putting so much energy into trying to solve what should be a simple scenario, but it's not, because there's a lot of social factors, there's a lot of behavioral factors, a lot of these other things. And what we've learned, of course, is so much goes unsaid in the PCMH models, where there are parts that are talked about by the care management teams, there are parts that are talked about by the clinicians, by the physicians, by the patients themselves, that aren't encoded right now in an electronic health record form. And making the situation even more complex is the care management is great if you're at the pediatrician, pediatricians playing quarterback, but then once you start to involve the specialists, and many of these kids also have very complex comorbidities that make this actually a very exacerbated and complicated situation. And so how do we get through that? And so how do we sort of encourage, while we might have great models, and the models are there, most of the models are empty, because the EHRs build these lovely templates. And the docs go, you know what, I need to get this patient through. I need to deal with this. The nurse says, I'm only going to put in the pieces that I'm going to act on clinically, as opposed to those things that are useful for improving the model. So how do we get past that on this simple use case?
Yeah, that's a great question. And I think, you know, you've got interoperable knowledge and you've got interoperable data, but these fundamental issues of what interoperable data do you have and how do you capture it? But I think there are things to start to do there, you know, and those include things like, golly, remote monitoring. So Maria's peak flows are captured digitally and nobody has to go enter them or ask or whatever. A second part of the answer, I think, is that as we go down the road, if it's really important to know, let's just ask somebody, right? The algorithm can say, golly, I really need to know fact X. I need to know your 6-minute walk time. Ask the patient what the 6-minute walk time is through their app or their patient portal or whatever, and you have it. You know, and then I think there's work on ambient monitoring and so on that may help with that over time. Having said all of that, though, there's still other, you know, there's models out there that are useful that there is the data for today. And even then, you know, and this has been really interesting over the last couple of years as we've been trying to do this work, there's still sometimes, you know, mismatches. So for example, you know, the interoperable versions of quality measures say a verified diagnosis of diabetes. How many people have a verified checkbox next to the problem list on their EHR? I mean, so there's these disconnects in the data to the knowledge that I think we have some real opportunities to improve as well, even on the stuff we have. So, yeah, great point. Thanks very much, everybody.
So what's the trick to advancing the slides here? Oh, okay. So what I just say next, is that it? Okay. Do I use this? Okay, keyboard. Got it? Okay, that's what I need to know. Okay, perfect. All right, well, so you've heard the context for this. I'm going to be talking about how public health fits into this overall framework. But I'm going to start by maybe making a controversial statement, and that is, as a technologist, as a standards development, this is not about technology or standards. Chuck was very prescient to recognize that we need to come together and come up with a consistent way of doing this. Could we solve this in 57 different ways? Absolutely. Any of you have been in the standards development gig long enough, you know that the same problems get solved over and over again with the next description. We've moved into the learning health system, which was part of a comparative effectiveness, part of personalized medicine. What are we trying to do? We're trying to improve outcomes, improve care delivery. What's happened now, we used to standardize data, right? And we will continue to do that moving forward. But now, everybody's got their piles of data, better standardized, still needs to be more standardized. Now everybody's accumulating piles of algorithms, right? And we'd like to see which algorithms work best together. And so I know I'm preaching to the choir, but that need is what we're trying to solve. And I would advocate that, if it's angle brackets, curly brackets, vertical pipes, I don't care. Let's agree on it. And I hope that this group might set a new standard for collaboration, cooperation, flexibility, and compromise to move forward quickly. Because, another founding premise, and I believe, Chuck, you came up with this, did you not, that computers plus technology, humans plus technology are better than humans alone. And I think that's brilliant. I would add as a corollary, there are discoveries in the data that we have that can change the world right now, if only we could discover it. And we're going to discover it through new models. And this group can help get those models, get the eyeballs of these models on that data to start improving the speed of discovery and improvement. I think that's the premise of why we're here. And I think it's motivating people to work together that's actually going to make or break what we're doing. And so now, on with the details and the technology and the process. The problem in public health, what are we talking about? Well, 30 years ago, we knew we were supposed to report notifiable diseases to public health. It's a simple fact, lots of simple facts in healthcare and public health. We don't do it. Physicians do not report notifiable diseases, the majority of them, to public health. That's the problem, despite the fact we know this. There are lots of things that we know in healthcare that we don't do. Why? Because we're overburdened. We need algorithms. We need automated processes to help us. So this was a study that we completed less than 2 years ago in Indiana. These are just the report rates by providers for different conditions. 0.5% report rate for hepatitis B. Syphilis, the number of true positive cases at 6.3% by providers. Faxing, we see slightly different numbers, so we can actually look at a provider report. We can look at faxing any kind of information, and then we look at an automated algorithm-driven approach that we've been running in Indiana for a couple of decades. Started off as triggered SQL queries in a database. It's moved on to expert systems, and now we are moving into machine learning algorithms. These numbers are from an expert system, not from machine learning. And then if you combine all of the numbers, this is what you can get to if we combine all of the forms of reporting. But the problem is human beings do not report. We know that. And so we need automated methods. This is just a schematic of our system. Our health information exchange in Indiana, one of the country's largest and longest, about 2 million transactions a day. Each one of them gets evaluated using these algorithms to decide if they're reportable to public health or not. The typical workflow is that the laboratory or whatever results deliverer or results creator creates a result, usually a laboratory result, sends that to the physician. Physician has to make a decision as to whether it gets reported. In Indiana, we're a dual report state, so both the lab and the physician are supposed to report. Neither do a great job. In our information exchange, that HIE NCD is the algorithm. So the transaction comes into the information exchange. The algorithm identifies reportability. We generate a reporting form for the physician, send that laboratory result, and then the physician can complete that and move it on to public health. So this is the type of workflow we are talking about. Now, in the use case write-up that I described, I added in a wrinkle here. So not everybody has a health information exchange. Lots of folks are integrated delivery networks. What if, right now, the reporting workflows that people are building into their EHRs for meaningful use is to say, if some human being somewhere recognizes this as being reportable, they can push a button and say report. No human being recognizes it's reportable. So what you can do with something like this is build in a workflow to analyze within your integrated delivery network, within your clinic, within your EHR, the ability to generate a flag so that the human being no longer has to be thinking all the time, is this reportable, yes or no? So whether it's in an HIE, whether it's built into another system, the concept is humans don't recognize it. We need algorithms to do so. We started working on machine learning algorithms, random forest, logistic regression, neural network support, vector machines, choose your flavor of the day. Algorithms work. I had a computer scientist with a master's degree take training and test data from our system. She knew nothing about notifiable diseases, implemented the algorithms, and beat everything, Mark Overhage actually helped to create this early on. Mark knows a lot more about notifiable diseases than our master's computer science student. But the algorithms she implemented with our guidance beat anything we had before. This line, just by way of example, why do these algorithms work? What do they teach us? What do the machines teach us? You see a horizontal line like this, alarm bell should be going off because nothing should be truly 100% sensitive. If it is, your recall or precision should be off, and it's not. So we looked at these results and said, what is wrong? Let me dig into this. Chlamydia, usually, you send in a culture. Cultures come back with free text, and people are typing in positive, negative, yes, no. I said, there's no way we accurately identified these. Well, the algorithm caused me to learn something. Turns out that nucleic acid amplification tests are now the new way to treat chlamydia. It says right in here, NATs are considered the test of choice for chlamydia and have replaced culture as the diagnostic gold standard. I didn't know this. I stopped seeing patients back in 2011. NATs produce positive, negative. The algorithms locked right onto that. That's right, those performance numbers are accurate. That's exactly, they are finding the positives and negatives that are coming out. So the algorithms are working and learning and seeing things that we can't see. The question is, which ones work best? So you can see on this slide, we're looking at all kinds of algorithms at this point, and we want to be able to convey what algorithm did we use for which condition, how did we parameterize it, what were the performance characteristics, what are the weights? All of these are knowledge artifacts that need to be communicated. And again, as we're working on notifiable diseases, somebody else might be working on pediatric asthma. That's not where we're working. I want to learn from Mark. I want to know what algorithm I need to implement. And we need ways of conveying this effectively and efficiently so that we can all benefit together. So that ends my presentation about the public health use case. But again, the algorithms are becoming increasingly powerful. The data is to the point where we can meaningfully implement these sorts of things. And we need CBK to help maximize the impact of what we're discovering. So I'll stop for questions now. Blackford, you were closest to the mic.
All right. I think maybe I beat Harold, I don't know. So Sean, thank you, great talk. It's a very interesting topic area because there's this correlation or
connection between public health reporting and clinical decision support.
Yep.
You know, the CDC actually is interested, and we're doing some work now with them to look at how, you know, to use the same logic to both do case detection for EICR, but then with case detection logic, apply CDS to the case and report that as well, so that the public health authority then actually knows the case was detected and it was treated appropriately or not. So I guess the question is really in that coupling, do you see those as two distinct knowledge artifacts, or do you see them as coupled, and have you done any experiments in that way?
I would classify what you're asking as a lumping, splitting question. I think long-term it makes sense to connect those very closely. In fact, I didn't talk about that work, but we absolutely do check for treatment after we've identified the case as well, because we pre-populate reporting forms. So the positive or negative reportability in our workflow actually triggers a secondary process. If positive, then look for any treatments related to that so we can populate the form to give to public health, who then can assess, okay, positive reportable, we saw that they were treated with Rocephin, great, excellent, we're done. Or do I? So I agree that combining it feels like there was a conversation previously about integrating all of these into a workflow. I think ideally, and to optimize the value of this, I do think at some point we need to chain these together. But I think we need to walk before we run, and chaining all of these artifacts to create a workflow feels to me like a goal, but probably I think we need to establish a clear foundation first. But, yeah, Harold?
Howdy, Sean, very nice. Just a quick thing. Patty was talking before about, in their 10 Commandments, about context. She was talking about how do you defining context. Can you say what you should be saying about context, or how your programmer is taking context into account, or is it irrelevant?
Can you say what you mean by context?
I was going to ask you that same question. So,
Okay.
you know, so on the one hand, it's really it's terrific that you have an algorithm that can speak to all these different places across the state of Indiana. Although I don't know how homogeneous Indiana practice is. Yeah. But is there something about variation in a community or in a state or something that should be known before you start applying, or is that incorporated or something? Yeah. So if I would now want to go to Maryland, if I want to go to New York, want to go to California with your algorithm, do I start from scratch, or is this, how do I combine those two?
So I do think that there are a lot of contextual factors, and I mean, I don't know how basic we want to go here, but every state in the country has 50 plus notifiable diseases. There's slight variation across states. So some of the notifiable, so I think you need to understand what is reportable, right, based on what definition. So I think that context is important, depending on how far you want to go with this. What do I do with the output? So if I say it's reportable, what then? What contextualize that? Who does this get routed to?
Well, I just really want to stick with it internally before we start running. I want to just stick internally, but the fact that the different, so you don't think there's differences in practice or demographics, it's really just what's notifiable. Right.
Yeah. I'm having a hard time hearing
Okay,
you.
sorry, I'll talk later.
Okay, yeah.
Thank you. This is Philip Walker. I'm just curious if you've tested the amenability of the algorithm. Should there be the unforeseen epidemic or outbreak to make sure you can pick up on things that need to be reported beyond the standard reportable diseases? Have you just tested whether or not we have this huge incidence of, you name your disease, Ebola, Zika, whatever, that needs to really get to the public? Can you tweak it to the point that it can get to that point of being used for epidemics?
Sure. So, when Zika virus came out a few years ago, we had to very quickly adapt the system for that. We didn't use these machine learning algorithms. We had to come up with what we thought were reasonable business rules to identify that. But it certainly is adaptable in that sense. But I heard you ask, can you identify the unexpected? And in public health, this is a case reporting system. So this is very specific, so we're targeting very specific defined entities. We also, in public health, and I know I'm preaching to the crowd, I was amazed to see how many people raised their hands when public health was asked this morning. In public health, we also have surveillance systems. So we have a syndromic surveillance system that expects certain trends, certain characteristics of the population, and when the population's trends don't don't follow the expected values, that can set off alerts. So that's one of the other ways that we look at the unexpected without knowing the expected.
Okay, thank you.
So thanks for the great presentation. So related to the context, I think there is, for example, whenever there's a model, machine learning model, there is underlying data, and there are different ways people tweak the models. They can prefer to make it more predictive, or they can prefer to make it more explanatory. So where do you think we can capture these preferences that are used when people create models?
Mm-hmm. So yeah, you're getting at sort of the explainability of a model, and I don't know that they're in direct opposition. I think you can have a highly explainable and a highly predictive model in some cases. If you can get into neural networks, then all bets are off. But so I don't see those as being in opposition. We're building some models for another use case right now. We're using something like LIME, the locally interpretable machine explainer, to get at that. I think ultimately the explainability is an open question. What is the degree? Early on, I actually thought, you know what? No physician is going to trust a black box. They're going to want to know why. But it's interesting, the hype and how we as a culture socialize this. I'm actually, as I talk with my my clinician colleagues, they're beginning to, they trust, how Amazon prioritizes what they should buy, and they're beginning to expect that, I'm going to trust this black box in healthcare. So I don't know the degree to which explainability is going to be important for day-to-day decision making. I do think there's going to be absolutely reasons why explainability will be necessary, but I'm rethinking where explainability is going to be important.
Education use case coming up next, and find these arrow keys of what I'm finding.
Good morning. Anderson Spicker, and I'm from Vanderbilt. Now we're going to turn our attention to education, which may be less obvious as an area of application of these important concepts. And we'll use a use case to illuminate our thinking and spur our discussion together. And this complements the written materials that you have. So I'd like to introduce to you an intern, a residency program director, and a primary care practice director. These are the data that I will highlight with this brief scenario from which knowledge can be computed. In this case, asynchronous learning exams, competencies, something called entrustable professional activities, or EPAs, patient care data, and personal learning plans. So we have Julie Drumright. She enters residency as an intern in internal medicine at an academic medical center. Her first week on the job, she's assigned to the ICU. She does have immediate goals to handle ICU emergencies and to hand off her patients to her colleagues after a shift, and to do so well. Long term, she's wondering what her career is going to be, and maybe she will start thinking about that even early in her internship. And of course, there's a residency program director who also has, among many goals, the idea that he or she needs to ensure patient safety and quality of care that the residents are providing, accurate and timely assessments of the learners as they're progressing, to discern where they're headed and to adjust their experience to tailor their progression and their needs. So Dr. Drumright begins her ICU rotation. Patient care duties for her this first week are light. And the reason is because she's still doing readiness assessments as an intern in the program, where she goes to the simulation center on the campus to perform with simulated patients various handoffs, various assessments. In this case, she is performing what are called EPAs, or entrustable professional activities. There are 13 of them that she rotates through, one of which is on the handoff of patients. That is EPA number 8. Unfortunately, she scores sub-threshold. This means that her supervising resident for this ICU rotation must be present when she hands off patients every day after work. She, therefore, is told, why don't you remediate by first learning more as you go. So she is encouraged to enroll in the Quiz Time Academy at the university there, which is an array of online ePortal learning materials that are provided to her through push-outs onto her phone. Every day she gets a quiz or a question about handoffs. She answers the question, and the answers to the questions are provided with references for further reading. So after more reading and experience, Dr. Drumright returns to the EPA station at the simulation center to remediate EPA number 8. This time she does well. She scores threshold. Her residency director therefore determines that it's okay for her now to be entrusted to hand off her patients to her colleagues without the supervision of her senior resident with her. Dr. Drumright moves through other rotations. She starts her continuity clinic. Meanwhile, as she's going, data is accumulating on her that's being captured and now presented in a readable online electronic portfolio of hers. The data that's accumulated is listed here in this box on the right. It can come from a variety of resources because it is complex, like the questions have already enumerated this morning in our other cases. Asynchronized learning that she may be doing. It may come from more simulations that are done later. It could come from the electronic health record data that is attached to her work. It also obviously comes from assessments from other residents and attendings that have worked with her. And then there could be measures from the health systems metrics that are associated with her care that also are imported into this presentable data format for her. Dr. Drumright's residency director obviously is monitoring the residents' progress, and he hopefully can see how folks are doing in a variety of formats and adjust experiences based on the students or the learners' performance, on their exposure to cases, on their emerging career decisions. Maybe Dr. Drumright's writing into the portfolio her learning goals. Maybe the residency director is seeing that she's starting to get interested in primary care, for example. He can see her clinical assessments, maybe her competency data, maybe her EPA data. He drills down and he can see here among the 6 ACGME competencies, he highlights patient care. He's looking over the past several months. And each of these data points represent an assessment that's been turned in on her. So he gets a general idea of how she's progressing over time. In addition, he might be interested in EPA data. Instead of clicking on competencies, he clicks on EPAs here and sees in this particular view, one of the EPAs recommend and interpret common diagnostic and screening tests, and can see how she is becoming entrustable according to those who've assessed her. He may look at her EHR data. Maybe there is patient care exposure information that's automatically being collected, or procedure data that are captured by notes that she's written, or procedure ID codes that are captured. In this example, potentially the residency program may think that there are 25 presenting problems represented here that the residents should see. And the EHR is automatically capturing that work by showing numbers next to each of these 25 problems, which represent notes that have been scored through natural language processing to be robust examples of the learner's exposure to that particular problem. For example, the residency director may drill down on cough here, click cough, and see within the buried note the concepts of cough that are captured by the system in this particular assessment plan on this particular note. In addition, there could be health system data as well, such as screening procedures in primary care clinic that are of interest to this residency program director, knowing that she is becoming more interested in primary care. And so he looks at the last several months or more of data of primary care screening procedures, the eligible patients that have come through her practice, and the compliant screening procedures that were done associated with her and her ordering, as they compare to what benchmark targets are for the practice. Blue being you made it past the target bar, orange, yellow meaning you're just under the group rate that we were setting for all you guys in clinic. All of these things become a portfolio potentially of data that's accumulating on this particular resident. Learner-centered data highlighted here, clinical outcome data highlighted here, and you and I can be imaginative about what that could be. All of it together forms potentially an interaction between a coach and a learner, between a residency director and an intern in this case, where they meet on some regular interval in their workflow to help elucidate her strengths and weaknesses, her career plans, and to review her learning plans. So the idea would be that, and that's where the expertise in this group comes together, that we take these data pieces that are coming in and leverage this educational and clinical data, combined with analytics that would enable trainees and their educators to really start getting after what I would say is education or evidence-based education, personalized education, such that this could potentially come together in some sort of knowledge support tool that might actually make recommendations automatically for the learner about rotations or kinds of patients or procedures or even mentors or research opportunities that exist in the current environment, assuming that there are information pieces about the context, as was pointed out in some of the earlier questions today, and such that this would be a comprehensive view of her development and somehow become transportable to the next phase, because there's going to be a primary care practice director who's very interested in this information, who's wondering how the candidates are coming from the local and distal programs, wanting to make a good hire, build case practice of competent providers, so that this person potentially would be able to see this presentation of this learner's progress to help make a good decision about the readiness of this individual to the next phase of training. So as Dr. Drumnight finishes residency, these analytical methods have been used to present her digitally, so to speak, to the next phase. And over the years in practice, just like for me as a PCP, and you can do it now, look up my data and find out just recently the survey information of the patients who've interacted with me over the last 3 months. This information will be set in big data that allows us all to have access to how this resident is performing in her practice. For her individually, it might alert her to areas that her outcomes are not as strong as they should be, which could stimulate her to the right learning opportunities to help her literally in her recertification process, but certainly in her desire to improve and to better herself. So just wanted to open our eyes together about how these concepts can apply to education. The things that we've written in your materials help illuminate some of those challenges and some of the work that many of us are about. Thank you for your attention. Questions?
Thank you for your presentation. I'm Alan Flynn from the University of Michigan, and my question, or maybe it's kind of a question and a comment, has to do with learning objectives in particular. Because what I perceive, and I started my career as a pharmacist and have now moved into information science, what I perceive in practice is that some models are going to become very important in and of themselves, and that practitioners are going to need to learn as part of their learning objectives about the models that are used in various medical domains. And it seems to me that's another connection for the MCBK world and the learning world. And so I wonder about your perspectives on that.
Thank you. I take that more as a comment than a question. I will say that we have great challenges standardizing learning objective language. And that becomes an identifiable way to articulate and clarify, for example, our context and our curriculum, such that we can find out simple things like where are we teaching what. And right now we're having a hard time figuring out how to automate that. Thank you. Joe Marks. Oh, sorry. Yes.
Hi, I'm Terry Wheeler from Weill Cornell Medicine. A great case example, thank you very much. I'm curious to know how you can capture the processing of information, the critical thinking skills that the residents need to practice, and what they identify as you attend with them on morning report and rounds, and how they're thinking and synthesizing that information. Would love
Let's
to hear
talk
your
more
response.
about how to capture critical thinking. I'll give you just one example. That example of NLP actually started with my particular context, which was being a clerkship director in internal medicine for many, many years. It was the concepts in the assessment and plans that students wrote that I felt were being missed in terms of giving them credit for the critical thinking that they were doing. For example, if a patient has chest pain, they would earmark that case as a case of chest pain. But all the negatives in their assessment plan, the patient has no shortness of breath, no productive sputum, would give that patient, that student, credit for pneumonia and shortness of breath concepts. What I'm trying to say is we need to think through how to capture the language of the trail of what is written to give folks credit for clinical reasoning.
All right. Hi, Anderson. Jamark Patton, Director of Educational Technology and Standards at the Association of American Medical Colleges, Director of the Medbiquitous program there. My question for you is around developing community. So we're all here as a part of this movement around MCBK, but specifically within the education space, I'm wondering, with the use case that you've given us, how can we bring others to the table to help move this forward? Because this is something that practically could be achieved, but it really is the willingness of people to be involved.
You're in charge of that. I will throw back to you in your new role at the AAMC and directing our efforts at Medbiquitous, where we think a lot about standards in medical education. So I think we need to illuminate this group to those entities and get more representation even here. Thank you.
Thank you.
Yeah.
Hi, Barry Ginsberg, American Diabetes Association. This is very interesting, and I think it's important, although we certify and recertify as physicians, to be sure. But a topic we haven't talked about is patient education, which in many cases is as important, if not more important, than diabetes, than the physician education. Certainly in diabetes it is. Any plans along that?
Okay. I am not an expert in patient education. I will defer to my colleagues on that. We do measure the ability to educate patients as part of communication skills within one of the 6 ACGME competencies. But to illuminate patients' understanding and their interaction, working through portals to understand that, I think that's a fabulous lane for us to talk about together. Thank you.
Thank you.
Hi, my name is Isaac Robinson. I'm an undergrad at Yale College. I'm curious what your thoughts are in terms of using this kind of interface or this kind of technology to monitor the mental health of the learners and look for signs of developing burnout or depression.
That's a really great question. Something we're very interested in, just received a grant on that front at our university. And that is, we actually do monitor, we actually do ask our trainees to in an anonymous fashion with the right coaches who have access to enumerate their learning goals, to learn career paths, to illuminate personal goals as well. And so the technology has the potential to capture that, again, people process issue of confidentiality and making sure that everybody's trusting in that environment. We're going to work on that with our residents as part of a multi-center study sponsored by the AMA. Thank you.
And our final use case is teeing up here. Jenny Larkin will present the research use case.
Okay, cool, thank you.
All right, and so the focus of this use case is looking at how computational biomedical knowledge can support and improve reproducibility of predictive models. And I'm just going to say that there was no planning ahead of time, but this use case that I'll be presenting actually came out of IMAG and the Multi-Scale Modeling Symposium that Patty Brennan presented on earlier. So that's a moment of synergy. Why I just wanted to talk just a minute or two about reproducibility and why this is so important, even though I think I'm singing to the choir. And what we're talking about here is computational reproducibility. If you have the same data, if you have the same computational steps and methods and everything, can you get the same result if you do it again? Which is different from replicability, which is if you do it, but with a separately gathered set of data, can you reproduce, can you repeat, can you have replicability? All right, it's always nice to have an example. So for example, you have these three nice people, you give them ingredients and you give them a cookbook and you say, great, I want a chocolate cake. And this is our idea, is reproducibility. They have all the same ingredients, they have the same SOP. Surely they're gonna produce the same chocolate cake. Well, they all produce chocolate cakes. Was it reproducible? I mean, there's no cream spinach in there. They all produce chocolate cakes. How reproducible is reproducibility? And this also brings into the point that there is also a sense of an art in there, right? There are personal decisions in the process that can affect the outcome. So this is part of what we're looking at. And as you all know perfectly well, there is great interest in the last few years in reproducibility, both in the outer world and at NIH as well. Everybody now gets to include this in their grant applications. And I just wanted to wax eloquent for a very brief moment and say that I really believe that reproducibility is a cornerstone of science. Art is an expression of personal vision, and you can see there's really good art and there's bad art, but whether it's Michelangelo or whether it's a kindergartner, they're still putting on paper their personal vision. Whereas science is seeking to identify the independent truth of the natural world. So for example, for centuries, scientists have been trying to figure out how are characteristics inherited, whether it was Gregor Mendel with his peas, or was Darwin sailing the world trying to figure out speciation, or people now looking at genetics and epigenetics to try to understand characteristics. They're trying to understand that in a variety of different ways. I don't want to dismiss the fact that there is a lot of skill in art. The methods and skills can be taught. But we all know that replicas are not necessarily the equivalent of the original creation. You know, oh, this song is just a cover by the original. On the other hand, sometimes the covers are better than the original. That's when they've become art in and of themselves as independent creations. In contrast, science, in order to be reproducible, it really relies on effective communication of the hypothesis, the methods used, the analyses that you did in order to establish the validity of the science as well as to support the reproducibility. And again, Patty Brennan already went through this very nicely in her presentation, all going from monographs through to publications, to preprints, and the cute little kitty octopus is GitHub. So there are an increasing number of ways to share computable biological knowledge and share knowledge in general in science. All right, so that was my prologue. So this presentation, I reached out to Grace Peng, who runs the Multiscale Modeling Consortium, and asked her if she had a really lovely example of reproducibility, and she reminded me of Ahmet Erdemir. Ahmet is the director of computational biomodeling core at the Cleveland Clinic. He's been doing knee biomechanics modeling for a long time, and he's very interested in moving his modeling into the healthcare delivery system. And much of the remaining slides came from Ahmet and his collaborators. So he's a bioengineer, he cares about knee modeling. And one of the important points is over the last few decades, biomechanical models of the knee have gotten much, much better. Part of this is there's much better data. The models, the computational models are better, and all this, they're better because the computer systems that they run on are much more powerful and faster. So you can see in this over the last few decades how much better the models have gotten. A side effect of this is everybody's like, yay, we can do models, we can make them better, we can improve them. So this is a number of publications about knee models in red. It's publications that refer to the knee and specifically finite element models. They've increased, so they're recently about 100 a year. If you look more liberally at publications that refer to knee and either model or simulation, that's growing exponentially. So it's a very active scientific area. Many people are active. There are a lot of models and simulations. This is when you start to worry, and the knee modeling and simulation community is starting to be very concerned about model reproducibility. Why? Because we know in general there can be a low rate of translation of preclinical findings into the clinic. That's just a thing in general. And they're also very aware that high-profile failures can cause the public to lose faith in research. So the knee modeling and simulation community sort of gathered their wagons and said, let's be proactive about this. And the question that Amit came up with was, well, the predictions that come out of these models, if we have all these different, very lovely complex models, if we give them the same target simulation scenarios, like what's going on if I just bend my knees with no weight versus if I have weight, and if we give them the same data, do they all give the same result? How reproducible are they? So what Amit did is he assembled an international group of engineers. All these people had their own biomechanical model of the knee. And they said, yes, we all want to work together and really look into reproducibility of our models. And they got funding through the Multi-Scale Modeling Consortium, and they're funded by NIBIB in order to study this. And essentially what they're doing, that's the diagram in the middle, so they all have the computational model of the knee, and all of these models have been informed by the common data, the anatomical properties, the mechanical properties of the tissues, as well as various loading scenarios. So all of these models are informed by the same data. Then they're all put through 4 different movement simulations, and they put out a mechanical response. And the question that they all have are, okay, these different models, are they giving similar predictions? Are they giving similar conclusions? Or are they different? So what is new in this organized approach is recognizing that there is a level of art as well as science in this modeling, and they're trying to document the modeler's choices to understand the effect of reproducibility. All right, so one of the things I did want to mention is the whole reason that they can do this is because this project is hosted on the MCBK platform. And that platform's been around for 10 or more years. It came out of the National Centers for Biomedical Computing, which was one of the earliest NIH Common Fund or roadmap programs. And as a project on there, you can see there's all sorts of information. You can get downloads and documents and forums and wiki, as well as the source code, and they can control how public it is. And MCBK is still supported by NIGMS. It is a free project hosting platform for the biomedical computational community that allows you to do all these things. And in her presentation, Patty Brennan mentioned that NLM may not want to do all of that, but may rely on external hosting platforms. MCBK is an example of that sort of thing. All right, so here's the research plan, and again, there's the data, common data that all the knee models are going to use. And then they develop specific models based on that data that comes in. Then they calibrate and benchmark the models, and then once all those models are prepped and ready to go, they put them through 4 different cases. So there's passive flexion, sits to stand motion, there's torsion, and another one, I forget. And then when they've done this, then they look at the output, and they do a comparative analysis of the models. And they're asking, are the modeling and simulation predictions influenced by variations in the decisions that the modelers did as they're creating their model? So what is the status of this? They're completing the specification of the models, and they're going into the benchmarking and calibration phases. These are the details about where they are in the progress of this, because they're only partway through this project. And again, the goal of this project is to determine whether the art of a modeler affects the ability to obtain consistent and actionable knowledge from the model, and if so, at what stage of the modeling or simulation life cycle. So those 10 steps that Patty talked about in her presentation, those are all the steps that this project is going through, because in fact, those are the 10 steps that Ahmet and the other members of the Multi-Scale Modeling Consortium pulled together. All right, so there are two ways this project could go as they're looking at model reproducibility. One possible outcome is, hey, yay, what happens if the predictions coming out of all of these 5 different models are the same? On the other hand, what does it mean if the predictions differ across the groups? Well, Ahmet's a half-glass-full sort of guy. So if all the models produce similar predictions, yay, we're already reproducible, aren't we a good community? On the other hand, it's not bad if they don't all produce the same predictions, because that's a really learning moment, because their goal is to not instantly be identical, but to move toward reproducibility and understand at a bigger level, how do you get reproducibility? So this is a tremendous opportunity. So for example, is there one model that's a little bit out of sync from others? That's fine, they can figure out why and improve it. Or maybe there's a certain simulation scenario that everybody fails at, but fails in different ways. There's a lot that can be learned through this reproducibility experiment. I just want to finish up by saying that I wanted to thank Ahmet Erdemir, as well as Carl Imhauser, his colleague from the Hospital of Special Surgery, whose reproducibility of models project this is, and they represent the Knee Hub project. I also wanted to thank Grace Pang from NIBIB, who's the head of IMAG and the Multi-Scale Modeling Consortium, as well as Andrew McCulloch at University of California, San Diego, who gave me some very useful and inspirational thoughts as I was developing this use case, even if they didn't all make it into this presentation. Thank you.
We do have a couple of minutes for questions or comments, and then we'll wrap it up.
So I think this shares some similarity with what Sean showed in terms of public health models. And I'm wondering if you could reflect from the point of view of MCBK, what kind of meta-level descriptors would kind of foster reproducibility? I mean, I see an experiment here of how you can get models or the same model to be handled the same by different investigators. But what would you do then if you were trying to make that those results available broadly? Is there kind of a level that we should be operating in to think about how to make that happen?
Yeah, so I might have skimmed over it a little too fast. There are actually 5 different models that have been built by different groups. They're all models of the knee, but they are developed differently in an attempt to simulate the knee. So the question is, when you've developed these different models, if you inform them with the anatomy and other material functions of the knee into these different models, do they all perform similarly or differently? So what you're going to learn is what are the so each of the modelers made different choices about how they were going to do a base simulation of the knee. And what this project has the potential of informing is what are the sort of better choices and what are the choices that actually don't seem to be as successful. In that sense, this is akin, in my mind, to the sort of challenges that you see, like in protein structure prediction in CASP or computers in cardiology, where they're given all the same data, and then everybody gets to bring their model to the table and run it, or their algorithm to the table and run it against the data set to see who gets closest to the true answers. That's a way for the whole field to move forward, to understand what is the best way of dealing with any specific challenge in a very transparent way.
Hi, thank you for your presentation. I'm Devere Gabriel. I'm from the Duke Clinical Research Institute. I've spent a good deal of my career dealing with ambiguity and the meanings of words. So I wanted to ask a couple of questions about the word research in terms of the MCBK work. Part of what I've worked on and have been concerned with is data models, and then the utilization of real-world evidence and aligning those with data models. And so I'm wondering, is this group concerned with, and when in presentation of this use case, models that foster discovery? So you're looking at validation, but for example, I'm working with a client who are developing algorithms that could actually then fall into this process, but they're ahead of or upstream of this process that you described. And again, I've done a lot of work in my career with common data models, semantic alignment, things like that. So I'm concerned about and wondering about the role of discovery in terms of this scope of work. Can you help me out with that?
Yeah, I think that's incredibly important. I would just say that this is a use case in the research realm. It is not the use case. And I think you raise a very important point. And it was a bit challenging looking at the entire breadth of research to try to find a single use case that might embody it. And I think you raised an important point.
Okay, so just want to put out there that is the kind of thing that personally I know myself and then my client, for example, would be interested in, from this group. It's understanding how to support discovery.
Yeah, so if I could be bold, I would say that my hope for this meeting is I've just put one example use case for research on the table. It would be great, and I think there's some other use cases from previous meetings, but I think it would be great to have a richer array of research use cases.
Hi, Jennifer Pacheco from Northwestern University. I'm a biomedical informaticist. I have a very similar question. So my work is EHR phenotyping, and algorithms these days are leaning towards a lot of machine learning and those kind of models, but in a lot of cases, patient populations from one place to another are different. So, a diabetes patient in one place is a different diabetes patient in another place. So how do we, what are your thoughts on having models that are reproducible, but there's different patients, you can't test on everyone, right? So how do you make a reproducible model to find diabetes patients when the diabetes is a simple example, but I'm sure there's better examples, but what are your thoughts on that?
No, I think that's a great question, and I'm going to chuck it over to my fellow panelists who I think were better suited to answer it.